Good morning, good afternoon, good evening, and welcome to the joint webinar between Harvard's Data Science and AI Summit for Health and the AI for Good webinar. Can image-based meaningfully impact COVID-19 response in low resource settings? We hope that you, your families, and your friends are all safe and healthy. My name is Bastiaan Kwast from the ITU, the International Telecommunication Union, the United Nations Specialized Agency for Information and Communication Technologies, joining today from Geneva, and I have the privilege of introducing today's webinar. The ITU is also the organizer of the AI for Good Global Summits, which are held annually in Geneva in partnership with XPRIZE, 36 sister United Nations agencies, ACM, and co-convened with Switzerland. The goal of the AI for Good Global Summits is to identify practical applications of artificial intelligence that can help achieve the Sustainable Development Goals. And like most of the world, the summit has gone online. We are publishing weekly webinars, solution tracks, and keynotes that will allow us to reach even more people throughout 2020. Today, we have a very distinguished panel featuring Judy, Margot, Eldad El-Nekave, and with the discussion being facilitated by Sky Gill. The panelists will present their remarks, but we're in particular counting on you, the attendees, to participate and create an engaging discussion. For this, we'll be using the Q&A functionality, which you can find just left of center at the bottom of your screen. You can also upvote questions that were posed by others that you would like the facilitator to ask. Additionally, there is the chat functionality, which you can use to have discussions with other participants. And please make sure that if you do that, that you set the message recipient to everyone and not just to panelists. You can select this just above the message box. Before we turn to our panel, I would like to ask everyone to use the chat functionality and to let us know where you are connecting from, which city or country. Please just type it into the chat and make sure you send it to everyone. That way we have an idea who's in the room. And in the meantime, I will just type Geneva, Switzerland. Okay, great. So we have people from Geneva, Jamaica, Denver, Kenya, Sao Paulo, Egypt, South Africa, many more. Well, I'm very much looking forward to an engaging discussion with this diversity of perspectives. And I think with that, it is now time for me to hand it over to our facilitator, Sky Gill from FIND. Hello, Sky, how are you?
Good morning, and thank you, Bastiaan, or good afternoon or good evening, depending on where you are based. It is early for me, so I have coffee. I'm very excited to walk you through today and to feature our three panelists talking about how image-based AI can meaningfully impact COVID-19 in the low resource contexts throughout the world. So the way this session is going to go is I will briefly introduce each of our three panelists. They're each going to speak for roughly 5 minutes about their work, and then we'll have a focused discussion for about 30 minutes talking about innovation, AI and COVID-19 in general, some specific challenges with image recognition in low resource settings. And then at the end, for about 10 to 15 minutes, we'll open it to questions from you all. So be thinking about some good questions. And then at the end, I will hand it off to Bastiaan to close. So introductions, a little bit about me. My name is Sky Gilbert, and I'm the Executive Director of Digital Square at PATH. Our mission is to connect health leaders with the resources necessary for digital transformation. And a lot of our work is trying to coordinate and align investment into digital health for low resource settings, supporting digital health software innovators in scaling their products, and then supporting country governments, hospital providers, and implementing those health software solutions. So for us, I was very excited about this panel because as software rolls out and scales and you're having large volumes of data and systems, it creates an opportunity to use AI for health impact because of the volume of data being generated. So very, very eager to hear from our panelists. I'm going to go ahead and begin by introducing Dr. Judy Warira-Gedoya. Judy is an assistant professor at the Department of Radiology and Imaging at Emory University School of Medicine. Judy, I'd love to hand this over to you to speak a little bit about your work.
Thank you, Sky. My name is Judy. My journey has been that I'm a physician from Kenya. I went to medical school in Eldoret in Kenya. So Jambo, all my Kenyan friends on the chat. And And so I went to medical school in Kenya. Then I came to the US for a fellowship in informatics, and I finally found my passion, which is to think about the rooms that patients receive care, whether it's the room is in their home or their room is in hospital. And so my interest has always been to work on technologies and see how they can save lives. And I'll start with a disclaimer. I think a lot of technology does not do good, in fact, has potential for harm. And so this also marks my interest in AI. So I'm an interventional radiologist by clinician, by clinical training and work, but I spend half of my time working on how to make technology safe and how to use that to accelerate care. And so along the AI, I am pretty much interested in figuring out when technology fails and studying that, and also advancing open science by supporting release of data sets and growing communities that can work with AI tools. In my non-AI world, I spent some time as a community maintainer for an open source project called LibreHealth, which is used to develop digital technologies in an open source community for use in emerging economies. And so if you have some time, you should check it out. But I'm happy to be on this panel and to look forward for an exciting hour. Thank you.
Thanks, Judy. It was great to hear from you. I think that one of the points that you made, that technology does not always do good, is actually a really important one, and something I hope we talk a little bit more about in the discussion. Our next panelist is Mr. Margot Bego. Margot is the Executive Director of the Chief Innovation Office at the University of Sao Paulo in Brazil. Welcome, Margot.
Hello, Skype. I'd like to share some slides, but first of all, I'd like to thank the Novartis Foundation for supporting our innovation and artificial intelligence program, and the organization for the invite. Just a minute, I put the slides here. I'd love to say hello from webinar colleagues, Judy and Helda, and to the audience. I just introduce quickly the Hospital das Clínicas, and then a short presentation about our projects with using AI to fight against COVID-19. HC Hospital das Clínicas is the largest hospital in Latin America, and it is connected to University of São Paulo Medical School. When I work with the Radiology Institute and the Innovation Center, the Nova HC. It has been operating more than 75 years and has 3,000 beds, more than 60 research laboratories, and in our area, almost 98 million of medical images started per year, and we have had 13 years of PACS with reports, a huge data lake here. At the moment, we operate 900 beds exclusively for COVID-19 patients here. And this is our project, AI project. This starts when our AI laboratory assessed how other countries were working with the AI in images, and we saw that there would be an opportunity to use algorithm to classify the likelihood of respiratory syndrome by COVID-19, and also to mark the area affected in the lung by the disease. But it's clear to have an algorithm to analyze CT images was an opportunity to fight the pandemic. But before, we have two problems to solve. The first one is how to convince the doctors to use the technology, and how to integrate it with the hospital, because most of them are in distant region. Brazil is a huge country, and the technical team at these hospitals are already very busy because of the pandemic. But with this project, these premises, we screened the market, search for the solution, the right solution, but we don't find no one, and that met all our needs that you need in the first time. So we had to design a cloud architecture with the possibility of connecting many partners working together. That's the idea. As a result, we arrive in this architecture. The name is the project is COVID-19, and that has a cloud PACS that we connect with the PACS or directly with the equipments in the hospital that they enter in the program. And the PACS receive the images from these hospitals, anonymize them, and send them to the algorithm platform that we have now there, two algorithms working together. And this AI algorithm analyze the images and send again to the platform the report, and the images mark the area affected by the disease. These images return to the hospitals, and they enter directly inside these packs. For solve the first problem, we put a set of experienced doctors to talk to the other doctors in the hospitals and discuss the case and issue a second opinion if necessary. And these images that we enter in the system, we store them in our data lake here. When we catch these images and we are creating data sets, and through our innovation program in Nova HC, we made an AI challenge to develop and plug the algorithm developed in Brazil on the platform. It's the new approach, the second phase. And this phase was launched yesterday. There is a site, and the Novartis Foundation is strongly supporting us in this process. And then we work we are here in the 15th June. And our proposal with this project is to increase in medical productivity using the AI, with the aid of AI, and standardize the process of marking the compromised lung by COVID-19, because we know that these areas change a lot. It depends on the doctors. But besides helping to fight the pandemic, for us, it's a huge opportunity to create an architecture for connect these hospitals and for the scale use of AI in Brazil, and also test methodology and a structure to develop a new algorithm for other diseases in the future. And that's the last one. Just finally, some numbers. This platform started and then May 4th, and the results so far, more than 20,000 platform access. We have 21 hospitals using the AI platform, and they have 16 in line to enter in the next days. We have already analyzing more than 5,000 exams, and every day 118 new exams enter in the platform on average. And that's it. I try to briefly convey the idea because the time and the project. I hope I have achieved that. Thank you, guys. I stopped the sharing.
Thank you so much, Margot. I think the topic of AI sometimes can feel very abstract or very complex, and I think a lot of your visuals helped bring to life a lot of what professionals are working on day to day. So thank you for that. It'll be interesting, I think, to talk a little bit more perhaps about the architectures as well, because that's a really important thing to get right. The final panelist today is Dr. Eldad El-Nakave. Eldad is the Chief Medical Officer of Zebra Medical Vision. Welcome, Eldad.
Thank you. Good morning, good afternoon, good evening to everybody. And I'm really thankful and privileged, honored to be part of this panel. A little bit about my background. I trained as a radiologist and similar to Judy, as an interventional radiologist, and I practice clinically as an interventional radiologist for about half the week. And then about 6 years ago, we started a company called Zebra Medical Vision with the goal of being able really to distill radiology knowledge, clinical knowledge, as it's presented in images and in reports, and translate that into something which becomes transferable to other stations, to other radiology stations, and in a way to be able to listen to sort of the insight of thousands of physicians who have reviewed imaging when they're not around, and really in the setting in what we're seeing now, I think that's even more important. I mean, there's nothing more important than that. And in the title of this talk, or the focus of the summit of this discussion, is around the use of AI in low resource settings. And I think in some regards, in the best sense, AI can offer something that distributes resources and insight across countries and into places where there are poor settings. And if we look at what we have here, we have very, very kind of resource intense and very dedicated people generating tagged data sets with a lot of collaborative efforts across disciplines to generate software, which then might be very useful locally, but also but critical in places where there are a lot of people sick and there are very few physicians and often very, very few radiologists to make the findings in a time-sensitive manner. And so that it fits really well with Zebra's vision and our clinical goals. And I'll just say, as a company, you know, we've been able to, in a sense, get a running start, because when we first saw the images of COVID-19 on CT, the radiologists in the group would look at it and say, "This, you know, this looks like we could characterize this. What looks similar to? There are some features, you know, cryptogenic pneumonia, and and other features like ground glass opacities that we said we have those, and we can identify those, and so we could actually begin to develop feature recognition software before we had a really adequate amount of typical COVID-19 data sets. And then with those data sets, take it a little bit further. And then also do something which we really like to do at Zebra, which is to see as much of the picture as possible, meaning that we're not just looking for COVID, but it's relevant to look at how much emphysema the person has. And if they have a lot of coronary vascular disease, what their liver looks like, and all of this stuff is available on a CT image, on a CT scan, and all of it is relevant in terms of a person's reserve. So I think it's given us an opportunity to really remember why we're here, and it's really encouraging, and it's great to see the contributions and the effort that I see even right here, and certainly globally, working to bring a good resolution to this. So again, thanks everyone, and I'm looking forward to hearing questions and more of this discussion.
Thank you, Eldad, and thank you, panelists. I think that I like the vision of using AI to improve the distribution of resources across different settings. I think that the promise of that, particularly where you have shortages of skilled professionals, could be very powerful. We're going to move into questions now. And so my first question is for each of the panelists to respond to, and it has to do with myth busting. So a favorite show of mine growing up was called Mythbusters, and in each episode, the host would take a common belief that most of us have and then use science to determine whether that belief was true or false. And I'd just like to know from our panelists, if you could bust one myth about artificial intelligence, what would it be? Maybe we'll work backwards in order from the introductions, and I'll come to you first, Eldad.
Just one. Okay. Look, I mean, this is something that so one myth is that it's intuitive. One myth is that it's intuitive. And as much as we as humans look at a picture or look at anything and we think we really we know what we're looking at, and we feed those pictures into a software, it's always humbling to recognize how many assumptions you've got to look at and how much ironing of assumptions you need to do to be sure that what you're presenting is really what you want a machine to recognize. And so I think, again, the myth is that it's intuitive, and it's a matter of taking what looks to us to be a good data set without many questions and just feeding it into some sort of pipeline and ending up with correct analyses.
I definitely think the more I learn about and see how AI progresses, the deeper my respect for the incredible processing power of the human brain. Let's go to you next, Marco. What is one myth that you wish you could bust in AI?
I think a question that I always hear is whether AI will make medical diagnoses and replace doctors. I think everybody knows hear the same questions. And because I'm an engineer, I don't have a conflict with these questions. It's for me. And I think in this case, it's my opinion, okay? In this case, I would say that it's not a myth that AI system make diagnose alone. And I think that's the idea with the AI and the forecast and the probabilities. But it's a myth that the AI system will make decisions alone. I think it's not to happen. I think it can say that the doctor will have the final say, but with a powerful decision system support. I think that's the idea of AI. And the AI system improve velocity and precision, but this AI system make decisions in place of doctors. I think it's not for now, and I think it's probably it's a myth now. But there are a lot of mythbusters and I don't know. But in my opinion, I think no, it's an AI not replace the doctors in the final say. That's it.
Judy, how about your top myth for busting?
So, I mean, Marco beat me to the punch here. I've also gone with AI will replace radiologists. And obviously I'm biased because I am a radiologist. But I'll go to AI is better than doctors. I think almost every paper is reported. AI beat doctors to pneumonia. AI beat doctors to, I'm pretty sure we'll have one for COVID if it's not there that I haven't seen yet. And so I think it's the question is when you read these papers or when you hear these claims, you should ask better than which doctor. And so if you think about how we train AI, it's usually at a cross section of time. Less than 6% of papers published in 2018 had even prospective validation. So you pick data, you decide, gee, I'm gonna look at COVID. I go to my PACS system. PACS is the imaging archive database, and I pull up all the images and label them. I decide whatever label that I want to use with this, and train this algorithm. The bigger the GPU resources you have, the more aggressive and the bigger network you want to train. And then you publish your paper maybe on archive or wherever, a peer-reviewed journal, and say that AI beat doctors. And so when you read this is very concerning, because when I was training through radiology, when I started my residency, the thing that I struggled with most as a first year was figuring out even the type of phases and how to organize my imaging for, you can imagine if you have photographs and you just want to organize them beautifully so that you can tell a story. That was what I really struggled with. And then the next step, when I was coming closer to completing my fellowship, what I cared most about was, could I measure these tumors and evaluate them in a quick way and effective way? And so then now as an interventional radiologist, when I look at images, I'm figuring out how am I going to save time so that I'm not using up so much radiation and keeping my case short? And so if you think about my evolution, AI doesn't grow like that, at least not today. In fact, we're funded by the NSF to sort of figure out how to train AI and human beings together so that AI can learn. And so when you say it's better than doctors, you have to specify better than who. Were you better than the first year Judy resident? Are you better than the interventional radiology Judy? And so this is a myth, and we need better ground truths and better benchmarks for comparison before AI is useful.
I think that's a really important point, Judy and Marco, around whether AI will replace doctors. And it sounds like there's a really big gap between the state of the evidence and some of the headlines that you see in some of these papers. I'd like to come, one of the conversations in the last few weeks, I was struck by how Eldad, you laid out what a good problem statement might look like for AI. And I'm wondering if that's something you can share, because I think that there's lots of energy around applying AI to many different kinds of problems. But I know that you have a perspective on some places where it might make more versus less sense.
Sure. I mean, and to touch a bit on what Judy and Marco were mentioning, AI may be better in finding one thing on an image. It's just, again, what's really here, the thing we expect of radiologists and of doctors is to see everything. And the challenge is that we tend to focus on a few things. So if there's a woman who's in the hospital because she has right lower quadrant pain and the radiologist finds the appendicitis, that's good. But if no one really expects them to also diagnose osteoporosis and to also diagnose fatty liver or to really see every evidence of an enlarging aorta. And so what I say this for is that our concentration and what we focus on is limited, and a good problem for AI to focus on, to come into a good problem statement or a goal is to help us to notice what we overlook systematically. And what I mean by that is that generally radiologists, we're really good at finding acute things and single things. And we're less good at making a global assessment and assessing for chronic conditions on every scan. And I think one of the greatest contributions of AI will be in utilizing the kind of ubiquitous, the tremendous amount of imaging that we obtain in order to conduct what we call opportunistic screens, the ability to find chronic conditions, then to assess them before they become acute. So that's one, I think, useful way that AI will be manifested in medical imaging.
Thanks, Eldad. You had a shout out in the chat on how you were sharing, and I saw someone say that the eye see what the brain knows, and I think that's very powerful. I'm wondering if you have a good problem statement. The next question is, what, as you're compiling your data set, what does a good data set look like to help for AI and for addressing the problem? And Judy, I'm wondering if you could speak to that.
Thank you for this question. So we are actually working on a data set. This is not from Kenya, but here in Atlanta, we are working on a data set for COVID. We have, right now we have around 1,800 chest x-rays, and I haven't looked at the CT scans yet, but so looking through the data set, one is, it depends on your final output, right? So if you want to, first of all, is determining the labeling pattern. So you can imagine we have the dictation of the reports. If you looked at the most recommendations for the radiology societies, initially, people are not, and it's true, you cannot look at least as a radiologist, I cannot look at as a chest x-ray and say that this is COVID. You'll say that these patterns can be seen in COVID, and sort of just the style of reporting. And so you can think about labeling for this data set. One could be just looking at the radiology report. you can think that the second one, and we are doing all three, is the second one is where you just open the chest x-rays, you provide labels. I think for chest x-rays, the most notable labels are the ones done by checks expert and the NIH dataset, which are the 14 labels for diseases, and then you add some about your probability and certainty around COVID. And then the third way we are looking at this is looking with relation to the testing that's done, whether we basically have the swabbing here for most of our patients. And so because we know that I have seen some of these x-rays that are actually normal. And so you have to determine how you're going to look at your ground truth and how you're going to provide that. And then the second thing is, if you're going to release this data set to the public, you have to think about anonymization. And anonymization, there's pixel level anonymization. And then if you want to release the clinical data set, you have to think about that too. And so one thing that we discovered going through our imaging is that we have pixel level annotations, which is just someone put like a date of the exam in the radiograph. And that's, that looks trivial to the human eye, but for AI, that's completely, first of all, you cannot release that data set to the public. And if you like putting a box around those labels, what we realize is that the AI algorithms, when we know this, they overfit and they start to learn, every time I see this box, this is from Emory University, and I know that this is the rate of the rate of maybe COVID among this data set, and I can cheat because we know that these systems do this. And as has been documented by many authors, including one for detecting pneumonia, which just learned which were the ICU radiographs by just looking at the amount of wires and the label at the top. And so data preparation is very, very difficult. And so obviously you could innovate internally by bringing the algorithms to your enterprise and running them internally and then sharing out what the performance is. But if we are going to make useful AI, I think we have to spend a little more time on the data, but that's sort of the thought process, at least from a practical perspective, about the challenges that we are facing right now.
Thank you, Judy. So you've got the complexity of searching for the right problem statement. Then once you have it, you have a number of challenges on getting the right volume of data, on getting it secure, getting it anonymized, getting it prepped for AI, and a lot of complexity that Judy outlined. And then when I think back to your slides, Marco, on top of all of that complexity, you had on your slides partnerships with Amazon, Johnson & Johnson, Novartis, Siemens, Huawei. So it looked very, very complicated. And so my question for you, Marco, is why is there so much partnership and collaboration in the AI field? And what if you didn't have all those partners, would it be simpler or would it be impossible?
Sky, it's not easy to connect all these companies. I think it's a strongly process, but in the first thing you need to connect and clearly all the interest of each one. I think that is the first idea. But and you have many factors to collaborate. I think that's the idea. You connect people and companies. Né? I'd like to. I think the two factor that the professors Judy and Helda said, it's very important to the motivation of the connection of companies and institutions. I think the first one, the data. I need a lot of data, and because of this, you need the Amazon and Siemens and GE, because they can collect this data for us. And I think we have heterogeneous data and organized. I think with the characteristics mentioned by Professor Judy, and connected this is very expensive and difficult. Therefore, collaborating data exchange is a good possibility to try to minimize these problems. I think it's when you think in data is easier. You explain for these companies what you need and what you can do together. And I think we have other condition for AI business system to be really effective. It's according to held out. I think that's the real change when using AI. You must analyze several problems at the same time. I think that's the idea. And it, according to Eldon, and it's true, AI using analyze one problem in the same moment. Because of this, I think many algorithms work together are necessary to do these things. And for that, it's easier working with partnership than to develop and deploy everything alone. Thus, if I think in we are without partnership, it would probably be slower, more expensive, and for a few users. I think that when you connect to more companies and more institutions, you can spread the AI idea. The development of AI seems to me to have a more adherence to a business ecosystem competing with another ecosystem. Because of this, I think you can connect to the company. Then with companies competing with each other alone. You know, I think the idea is the ecosystem working AI. I think it happens, and I think it sounds and works good. Then we stay alone.
Thanks, Marco. I think that, you know, to solve some of the challenges you highlighted, it sounds like there's some really key areas where those partners bring value. So some of that complex navigating and brokering of partnerships is worth it. Wanted to turn to talk specifically about COVID-19 and ask each of you, since COVID-19 became a global pandemic, what's changed about how you work? And perhaps Judy, we can start with you.
Thanks, Kai, for this question. So, you know, I'm pretty much involved in direct patient care because I do procedures on patients. So really for me, what changed was the workflow of bringing patients to do procedures for them. And but in the context of this talk, I'll mention something that I noticed that changed for the workflow of the radiologist, right? And so everyone is very interested on focusing on, you know, the images, but we forget that there's the cameraman who goes to the field and takes these amazing pictures for you to work on AI. And so we saw a lot of people move back home as a sort of to remove the doctors from the hospitals. And most of those people were actually radiologists, because as long as you had a good internet connection and a home workstation, that most people could actually work from home. And so we saw that, and also to decongest the working spaces so that people did not have to be too close together to reduce the risk of person-to-person transmission. And so, but the person who sometimes is a little forgotten in this journey is the technologists, the ultrasound technologists and the CT technologists who are in this patient's room taking pictures. We know that for just taking a CT scan during COVID was extremely and remains very difficult, because for our institution, you had to bring the patient. The room has to have a terminal clean. And so you're talking of a turnaround time of around 2 hours just for imaging. And so you have to ask yourself, do you really need imaging? Is this going to change your management? And so I saw myself going to the patient's rooms to do the procedures in their rooms with ultrasound, because bringing them, well, first of all, you have to figure out what hallway are you going to bring them in. Is it who, you know, are you going to make sure that people are clear? And then the room that you have to use will go down. And so I think this is a good reminder, specifically for not just the technology itself, but to think about the impact and the people around. And if you kind of look at how most, quite a number of companies have always sold their product, is saying, we'll make you faster. But I don't think for AI for COVID is faster is what's needed. The rate of cameras and pictures that can be taken is already low, because patients don't want to come to the hospitals unless they need to. And the throughput of the machines is low. And so we need much better value return more than just saying you're faster. And so that's personally how my life changed in terms of work.
Judy, I think that's a really important insight, that even if AI removes risk for certain populations or enables, remote work for some, that in other contexts, and particularly around data collection, it can create more risk, and potentially some of the work can also increase cost, and so it changes the ROI. Marco, how have things changed for you since COVID-19?
Sky, I would say that's the biggest change was in speed. I think everything suddenly got faster, suddenly, and decisions, approvals, and the need is everything. And for example, what we did here in the last 2 months, probably under normal condition, would take at least 6 months. I think that the velocity is so high. And because I think the other trend, but connect with them, is same Judy said in a part of the speech, is the use of the electronic communication and collaboration tools. They are practically part of the everyday life now. And in many cases, I believe probably they stay here they are here to stay, this change. Can I imagine? I think this two connection, the speed and the technology, I think it's enter a lot in my day. My schedule was full for at least 2 months, and I probably in the next month too. I think that's the big change, besides the other change and the social distance and kinds like that.
Thank you, Marco. And Elzad, how about you?
I have some resonance with Marco's sentiment of experiencing rapid collaboration and less bureaucracy, and kind of and cooperation on the one hand. So the sense that you can get things done, and you can get things done because this is an important time to get things done. On the other hand, an overall sense of a bit of bewilderment. A lot of things, the securities that we took for granted, were just not there, and we didn't know. And we had a whole IR section of a different hospital that couldn't provide services because one of the nurses was sick, and everyone for 2 weeks was gone. And so we split the team into two in case one of us got sick. I mean, these were some of the experiences that kind of revealed the facade of security that we live under and we have to live under. On the other hand, there was real action and progress, both in the hospital and also for Zebra as a company. And if I'm honest, if I'm honest, I think the biggest difference was that I was doing a lot of work, trying to do work, not doing work because my daughter wasn't in school. So it was just a lot of time, like that. I think that's an experience a lot of people have, of having to do it all and prioritize. And I think it made us I think it made most of us very efficient and focused on what we want to achieve.
Thank you. My final question before we turn to the audience questions is specific for low resource settings. And I would just love for the three of you to share in your mind, what is the biggest opportunity you see right now to provide value in low resource settings in addressing the COVID-19 pandemic? And coming back to Judy's point that technology is not always good, what is the biggest risk you see? And Marco, why don't we start with you? Marco, can we start with you?
Sorry, Sky. I have a problem with the camera and the microphone here. Sorry. I think the risk is, I'd say that is like a challenge, and I think AI-based systems will be to reduce the cost of the healthcare and not to increase it. I think it's a risk that you have, because I think it is to stop the existing trade-off in Brazil. It's common in healthcare today. You add in new technology, and always this technology increase costs in healthcare, in the equipments and the service. I think that's the biggest risk that you need to or the challenges that you have in this moment. You need to use the AI, the technology to reduce the cost. And I think there are other risks is according to Judy and Hannah, the data. Now you need to have the using data, and you can't to connect all the data that you need in the faster, and because and you need to stay compliance with the privacy laws and the regulatory. I think that's, you need to think about it. If you have if the best laws and regulatory and the regulation that you have to improve the technology and improve the AI faster. And I think it's I think that's it. I think the other idea is to, I think you can use it the moment it's an opportunity and a risk and opportunity. If you not use the moment to introduce the technology in the medical practice. I think that's a good idea. According to Helda, you need you have new needs, you have new problems, and it's an opportunity to use the technology to change the status quo in these moments. I think it's a risk that you need to fight them and promote the change that we need. That I can think in this moment, Sky.
Judy, would you like to go next?
So, I noticed the webinar is about imaging, imaging, and specifically, so when I hear imaging, I think more of, computer vision in terms of AI and COVID. And so we're essentially talking about radiology images. And I just think that chest x-rays, I don't know that there will be much value in terms of specific saying that you can use this for diagnosis. Maybe more things will come up on this, but just seeing what I have worked on and seeing sort of testing the algorithms that are out there, the performance is really bad. And so I think maybe CT scans and maybe getting other markers or quantifying disease. There are other interesting questions that you can ask from this. I think we can see some of those on the chat, people asking these patients more procoagulable or something like that. And so this power of AI to analyze large data sets, and also so across multiple institutions, but also in areas where we are blinded to, as mentioned earlier, I think is a potential for good. I think that, recently I actually asked my mother who lives in the village in Eastern Kenya, and I asked her what she thought about AI. I actually asked her just for a presentation I was doing. And, we've never talked about this. And I asked, about something similar, which is M-Pesa, which is a mobile money transfer system widely used in Kenya. And I asked, this changed your life. So what would be that changing? What would be the M-Pesa app for you? And still, I think it made for an interesting discussion, because I know that these technologies do not always get to the last mile of the people that need them. And so this just reminds us here that when we design and build these technologies, we have to understand the context that they're used. And so always assuming Africa as a country more than a continent, specifically I'm speaking about Africa, is a way to fail, because we're so diverse and so different, and you have to understand that. I see a gap in lack of regulation, specifically on sort of like what's the gold standard and what that means specifically for like licensing. It's very difficult to just come up one day and just use this system in a US system versus just putting up something in Kenya and going ahead and using it. I think it's a little easier. And so you have to hold yourself to the standard that if you're deploying or developing these technologies, that you would want your mother treated with them, and hopefully you love your mother, and that you want to do them with the best standard, if not even a higher standard, especially in areas where there are not these protections. And so I see I don't honestly see the rapid scale, the rapid acceleration, I agree, and in terms of partnership has been very big, especially where there are many regulatory bodies. But going back in places in the emerging economies, we know that you can bypass these regulatory issues very easily, and that has potential to cause harm. And so it requires like this good citizenship to make sure that we are good stewards for our patients and for our families.
Thanks, Judy. There were some questions about regulatory in the Q&A, so we might have a bit of, at the end, come back to regulation. I'd just love to hear your thoughts, opportunities and risks.
I think I spoke a bit about the opportunities before, and the concept of basically distilling, if you distilling the insights of physicians in AI, whether it's in imaging or elsewhere, that becomes a resource which can really be potentially distributed well in resource poor settings. But apart from that, really, I think that Judy and Margot had a lot of insightful things to say. I don't have much to add to that. And I really do agree very strongly with what Judy said about regulation and the responsibility of anybody working in a place where there is a lack of regulation. There's a lack of regulation because there's a lack of resources. It's not because people don't care. And so, it falls on your shoulders to make sure that what you're delivering, is valuable and is safe. So thanks for that, Judy.
Thank you. So I think our first question is that I wanted to come back to is actually the one on, there was a great question on regulation, and just bear with me a moment because in the open question set, I'm just trying to find it. Let's see. Here we go. It's from TJ Mizra. Thanks to all the panelists for participating in and ITU for creating this event. I'm interested in the effect of current and anticipated regulation across industries, borders, etc., on the purity or intentionality of the problem statement. In this, as I ask questions, I think panelists, if you want to respond to the question, just go ahead and activate your video, and then you can go ahead and start speaking. And if there's two of you, then I'll call on one.
So I can go ahead and attempt to respond to Misra. And so, I mean, I don't think any one of us knows how the regulation will change, but we can know what are the impetus for change in regulation. One, I don't anticipate, apart from Europe and the GDPR, I don't anticipate that we'll have this sort of block regulation. So for example, like across the African continent, and I think it's going to be very country specific. But we know things that accelerate regulation. And one, we see sort of like how the FDA is struggling with sort of regulating AI. One is if you regulate it as a device, then you're saying, gee, I don't want you to keep changing fundamentally. And once you submit your test data set, which can be just in number of tens, not thousands, then, and we give you approval for this, you cannot make big changes around this. And so those type of regulations are very, they can be very difficult, as if you're on this panel and are a technical user or developer of AI, you know that, I mean, like the GPT system for terminologies has just come up almost every couple of months. There's an improvement. And so it's very difficult to figure out how you're going to deal with software updates, or how you're going to deal with distributional shifts, which is where data changes because you have a new system. Or right now, every pneumonia we're seeing is COVID, but once everyone starts to get into hospital, or we go to the fall and we'll see new types of pneumonia, that the distribution of the incidence and the prevalence of disease changes among your data set. How do you deal with that? So there's this post-market surveillance that I think we're all trying to figure out how to deal with that, and it's not necessarily regulated. And so I do think that things that can accelerate regulation is harm. If something drastic happens, we will see faster regulation. But I'm not so sure that, I think there's a related question about the Ministry of Health, that we are ahead of this or thinking about this and figuring out how to work on these types of regulations, especially in low and middle income countries.
Thanks, Judy. That was an articulate answer to a very tough question. I think the final question we have time for today has 3 votes. It's from Antonio Dinicelli and ties into some things that we've talked about, but I think actually could be quite interesting because it's very specific. It's that COVID-19 is typically diagnosed with a test. How is it superior to use image analysis of lung scans instead? If the answer is that it's cheaper, more accessible to remote locations, what is the comparison of sensitivity specificity with a test versus diagnosing from lung scans? So I think this harkens back to, is this really a good problem statement? And if so, what makes it a good problem statement?
I can take a shot at this. So there's there were some early papers from China that were interesting in that they looked at CT scans of people who presented symptomatically but were negative in terms of PCR, and found that there were a significant portion of people who had classic findings on CT but were negative, and then had repeat exams over the course of a week, and 90% of them converted to being positive. And the overall sensitivity on that, from that study, was that the sensitivity, well, depending on what you call the gold standard, but the gold standard was the PCR, but it was the PCR with symptoms. So if someone was asymptomatic, then it was 3 PCRs over the course of a week. And the gist there was that the imaging was superior in terms of sensitivity and specificity. It's a challenge to make that statistical analysis because of the bias and when you actually perform imaging. But what I will say is that you're not going to get certainly a CT scan on everyone who you think may be sick. Some of the advantages are that it's you kind of have a sense right away. The other is that there's other data apart from positive or negative in terms of the study. So the evidence of other comorbidities, certainly lung comorbidities and cardiovascular, that's important information. It may be important for triage, both in terms of the scope, the magnitude of the actual disease, COVID, and also the magnitude of underlying disease. I'll leave it at that. I have more to say, but I think that's my brief answer, is that that the imaging is very rich data. It's not binary. It is immediate, but it's also expensive and not all that available. And that's so those are the pluses, the advantages and disadvantages.
Thank you, Eldad. I'm mindful of time, although there are many other great questions. So I encourage you to connect with the panelists on LinkedIn or with each other, because I think that there's rich discussion that we've started here. And thank you all for participating and engaging and having such a rich dialogue. And many, many thanks, Judy, Margot, and Eldad, for your wisdom and insights today. I'm going to go ahead and hand it over to Bastian for closing.
Yes, thank you very much, Sky, and thank you. A big thanks to our panelists and the participants as well for making this a very engaging discussion. And before we wrap up, I would like to highlight a few things that may be of interest to our participants. First off, together with the World Health Organization, the ITU has for the past 2 years been convening the focus group on artificial intelligence for health, which is an effort to create a benchmarking framework for the accuracy of AI in health diagnostic aids. And this also in particular tries to address some of the issues that were raised just now on the discussion. Participation is open to everyone, and we are looking for experts to contribute in a wide range of topic areas, such as retinopathy, tuberculosis, and many others. We are pasting information on this in the chat, as well as a link that you can use. This Thursday, the day after tomorrow, we have a webinar on AI driving digital divides and the future of African economies, followed by next week's webinar on Wednesday, the 24th, the global dialogue on esports. And we're also posting this information in the chat, so you can use those links to register for the webinars. You can also find this information, as well as much more background material on aiforgood.itu.int. And with that, we have reached the end of this webinar. I would like to once again thank everyone involved, our panel, our participants, our partners and sponsors, and the co-convener Switzerland. Thank you very much, and I hope to see you all on Thursday.